Next is lower respiratory tract infection. So, respiratory tract infection is one of the major cause of morbidity from acute illness for which patients seek immediate medical attention. So, majority of all pulmonary infection follow colonization of upper respiratory tract with potential pathogens, that is bacteria, whereas microorganisms less commonly gain access to lungs via bloodstream from the extrapulmonary source or by inhalation of infected aerosol particles. So the competency of the patient's immune system plays major role. That is, they determine the susceptibility to infection and etiological cause and disease severity. So, an appropriate treatment regimen for the patient with uncomplicated lower respiratory tract infection usually can be established by patient history, physical examination, chest radiograph, and properly collected sputum for culture, and interpreted with current knowledge of most common lung pathogen and their antibiotic susceptibility pattern with one's community. So lower respiratory tract infections include bronchitis, that is divided into acute bronchitis and chronic bronchitis, bronchiolitis, and pneumonia. So bronchitis. First is bronchitis and bronchiolitis are considered as inflammatory conditions of large and small elements of tracheobronchial tree. It is an inflammatory process that does not extend to alveoli, and bronchitis frequently is classified into acute and chronic. Whereas acute bronchitis occur in all ages and chronic bronchitis primarily affects the adults. Then bronchiolitis is a disease of infancy. Mainly infants are more prone to bronchiolitis. So let's see what is acute bronchitis. So epidemiology says that acute bronchitis occurs most commonly during the winter season, and that is followed by a pattern similar to that of acute all respiratory tract infections. Then cold, damp climates, the presence of high concentrations of irritating substance such as air pollution, cigarette smoking, that all things can precipitate the attacks. So coming to the etiology, respiratory viruses are most common infectious agents associated with acute bronchitis. For example, common cold virus, rhinovirus, coronavirus, then lower respiratory tract pathogens including influenza virus, adenovirus are majority of the cases. Then in children, addition of para-influenza viruses also cause the attack. Then Mycoplasma pneumoniae, Chlamydia pneumoniae, and Bordetella pertussis, that is in case of whooping cough, can also cause acute respiratory tract infection. Then in the case of bacteria, Streptococcus pneumoniae, Streptococcus species, Staphylococcus species, Haemophilus species may be isolated from the throat or sputum culture, is contaminated by normal flora of upper respiratory tract, are some of the pathogens. Then bacteria etiology. In the case of acute bronchitis, bacteria etiology appears to be rare. Then secondary bacterial infections may be involved. So pathogenesis for acute bronchitis is majority of the acute bronchitis is self-limiting illness and rarely a cause of death. So in general, infection of trachea and bronchi is hyperemic and edematous mucous membrane with an increase in bronchial secretions. So destruction of the respiratory epithelium can range from mild to extensive and may affect the bronchial mucociliary function. In addition, that is increase in bronchial secretion which can become thick and tenacious, and further it impairs mucociliary activity. So the probability of permanent damage to airways as a result of acute bronchitis is unclear. Then the recurrent acute respiratory infections may be associated with the increased airway hyperactivity and this follows the pathogenesis of asthma or chronic obstructive pulmonary disease. Coming to the diagnosis, mainly by history and physical examination, then bacterial cultures of expectorated sputum. Generally, it is because of the inability to avoid normal nasopharyngeal flora by the sampling technique. Then in routine cases, viral cultures are unnecessary and frequently unavailable. Then viral antigen detection test developed to identify the respiratory viral antigen can be used. Then cultures or serological diagnosis of Mycobacterium pneumoniae and culture of direct fluorescent antibody detection of Bordetella pertussis should be obtained in prolonged or severe cases with when epidemiology consideration would suggest their involvement. So in the case of acute bronchitis, if there is complicating bacterial superinfection is absent, almost all cases it will be self-limiting. So then the goals of therapy will be is providing comfort to the patient and unusually severe cases to treat associated dehydration and respiratory compromise. Then coming to the pharmacologic therapy, mild analgesic or antipyretic for lethargy, malaise and fever. Uh, Acetaminophen 650 mg in adults or 10 to 15 mg per kg in children. Maximum daily pediatric dose of 60 mg per kg. Maximum daily adult dose of 4 gram. Then ibuprofen 200 to 800 mg in adults or 10 mg per kg in children. Maximum daily pediatric dose of 40 mg per kg and maximum daily adult dose of 3.2 grams should be administered every 4 to 6 hours. In children, avoid use of aspirin because and use other than aspirin, use acetaminophen because of the chance of Reye syndrome. Then ibuprofen was an antipyretic and it is identical to that of aspirin or acetaminophen. And the duration of antipyretic effect may be slightly longer. That is, for example, 3 to 4 hours of aspirin and acetaminophen versus 5 to 6 hours of ibuprofen. Then caution should be taken for administration in younger than 3 months of age and elderly patients and individuals with poor renal function. Then aspirin and ibuprofen inhibit prostaglandin synthesis, thus adversely influence the renal function. Then patients should usually take OTC for cough and cold remedies with combination of antihistamines, sympathomimetics and antitussives. These agents dehydrate the bronchial secretion and hence they will aggregate and prolong the recovery process. Then persistent mild cough is there. Dexamethasone can be included. Then more severe coughs, intermittent codeine or similar agents can be given. In severe cases, use mild sedative hypnotic for the cough suppression. And routine use of antibiotics should be discouraged with persistent fever or respiratory symptoms for more than 4 to 6 days. The possibility of concurrent bacterial infections should be suspected. Then start antibiotic therapy for anticipated respiratory pathogen. So pathogens should be identified first. Then Staphylococcus pneumoniae, Haemophilus influenzae and Mycobacterium pneumoniae, erythromycin, clarithromycin and azithromycin can be given. Then alternatively a fluoroquinolone, that is jatifloxacin and levofloxacin can be included. During epidemics of influenza A virus, amantadine and rimantadine can be given. Then new drugs such as zanamivir and oseltamivir are active against both influenza A and B virus. Coming to chronic bronchitis. Chronic bronchitis is a condition of inflammation and swelling of lining of airways leading to narrowing and obstruction that generally results in daily cough. The inflammation stimulates the production of mucus, which can cause further blockade in airways. So, acute chronic bronchitis is a serious progressive lung disease that can be controlled but not cured. Then emphysema and chronic bronchitis are the most common conditions that may lead to COPD, chronic obstructive pulmonary disease. Coming to the epidemiology, chronic bronchitis is a non-specific disease that primarily affects adults. Then about 10 to 25% of adult population of 14 years of age or older are more prone to chronic bronchitis. Common bronchitis include acute and chronic bronchitis. Approximately 14 million physicians visit per year in US. Similar to acute bronchitis, cold, damp climates and presence of elevated airborne concentration of irritating substance may favor to this condition. Then chronic bronchitis is usually more common in men than in women. So coming to the etiology, chronic bronchitis contributing factors include cigarette smoking, exposure to occupational dust, fumes and environmental pollution and bacterial infection. And then the influence that of each factors or others either alone or in combination contributes to chronic bronchitis. No history of smoking can be identified in as many as of 10% of patients. Then alpha 1 antitrypsin deficiency can also cause this chronic bronchitis. Then recurrent respiratory infection at a young age may predispose individuals to develop chronic bronchitis. In the case of chronic bronchitis, pathogenesis include chronic inhalation of irritating substance. Uh, it causes a normal secretory and it affects the normal secretory and mucociliary function of bronchial mucosa. In chronic bronchitis, the bronchial wall is thickened and the number of mucus secreting globulate cells in the surface epithelium of both larger and smaller bronchi will be getting increased. Then in contrast, globulate cells generally are absent from smaller bronchi of normal individuals. That is, increased number of globulate cell, hypertrophy of the mucus glands, and the dilation of the mucus gland duct are also seen in chronic bronchitis. Thus, the chronic bronchitis are more mucus in their peripheral airways, further impairing normal lung defenses. Then increased quantity of tenacious secretions within the bronchial tree that will frequently causes mucus plugging in smaller airways. So these changes are in squamous cell metaplasia of the surface epithelium. Edema will be there and increased vascularity of the basement membrane of larger airways and variability of chronic inflammatory cell infiltration will occur. Then continued progression of this pathology can result in residual scarring of the bronchi, augmenting airway obstruction and weakening of bronchial walls. The major clinical presentation includes, and that is major signs and symptoms include cyanosis, bluish coloration for skin due to insufficient oxygen. Then it will be seen in advanced stage. Then obesity. In progress stage of chronic bronchitis, we can observe cor pulmonale and including cardiac enlargement, hepatomegaly, edema of the lower extremities, then cough, mild to severe with productive purulent sputum, then expectoration of large quantity of sputum, usually in the morning time, then expectorate, usually tenacious with varied color, that is from white to yellow green. Thus, patients complain of bad taste in their mouth of halitosis. These are the major signs and symptoms of chronic bronchitis. Then coming to the diagnosis, any patient with coughing or sputum on most days, at least 3 consecutive months of year, for 2 consecutive years has chronic bronchitis. Then those with simple chronic bronchitis and chronic or recurrent mucopurulent bronchitis, and those with chronic obstructive bronchitis based on the PFT pulmonary function test can be identified. Then physical examination, that is just oscillation, usually reveals inspiratory and expiratory rates, rhonchi, then mild wheezing with a prolonged expiratory phase. The normal vesicular breathing sounds are diminished because of clubbing of digits. Then chest radiograph shows that increase in anterior posterior diameter of thoracic cage. Then depressed diaphragm with limited mobility. Then laboratory test shows the erythrocytosis. It will be seen in advanced stage of disease. Then PFT pulmonary function test, decreased vital capacity and prolonged expiratory flow can be seen in patients with chronic bronchitis. So for the diagnosis purpose, sputum culture should be done. Common bacterial pathogens involved in chronic bronchitis, majority will be Haemophilus influenza and minor will be Pseudomonas aeruginosa. So based on the classification, that is chronic bronchitis is classified into class 1, class 2, class 3 and class 4. Then class 1 category, that is acute tracheobronchitis. In this, the criteria for acute tracheobronchitis is no underlying structural disease is there. Usually viruses are the pathogens, and then initial treatment is amoxicillin and amoxicillin clavulanate or macrolide antibiotics can be given. In the case of class 2 chronic bronchitis condition, that is forced expiratory volume will be more than 50% predicted value. In this case, increased sputum volume and purulence will be there. Then usually pathogens identified in the stages Haemophilus influenza, Haemophilus species, and streptococcal pneumonia, that is beta-lactam resistant species will be there. Then initial treatment will be given by amoxicillin or fluoroquinolone if prevalence of Haemophilus influenza resistant to amoxicillin is there. Then fluoroquinolone, amoxicillin, clavulanate, azithromycin, tetracycline or trimethoprim sulfamethoxazole is given. In the case of class 3, chronic bronchitis with complications are there. That is, forced expiratory volume will be decreased 50% as of predicted value. Then increased sputum volume and purulence will be there in this stage. Advanced, it will be more due to advanced stage, at least 4 flares per year or significant morbidities will be there. Then class 2 usual pathogens in this case is class 2 Klebsiella pneumoniae, Pseudomonas aeruginosa and other gram-negative organism. Then treatment will be treatment options are fluoroquinolones can be included. Expanded spectrum cephalosporin, amoxicillin, clavulanate or azithromycin can be given. In the case of class 4, chronic bronchial infections are there. Same class of class 3. Then year long production of purulent sputum is there. Then usually pathogens isolated are Klebsiella pneumoniae, Pseudomonas aeruginosa, and other gram-negative organism, same as that of class 2. Then oral or parenteral fluoroquinolone or carbapenem or expanded spectrum cephalosporins can be included in the class 4. Coming to the goals of therapy of chronic bronchitis, to reduce the severity of chronic symptoms, to reduce the acute exacerbation and achieve prolonged infection-free intervals. Coming to the treatment options, there will be non-pharmacological and pharmacological approaches for the chronic bronchitis. First is non-pharmacological. The approach to treatment of chronic bronchitis is multifactorial. That is first and foremost, the attempt should be made to reduce patients' exposure to non-bronchial irritants, that is smoking, etc. Then a complete occupational or environmental history for the determination of exposure to noxious irritating gases. Then patient to reduce the or eliminate completely the number of cigarette smoking daily. Then to reduce the exposure of second-hand smoking is there. Then coordinated smoking cessation program, which includes counseling and hypnotherapy. Then adjunctive use of nicotine substance such as nicotine gum or patches may promote the reduction of complete withdrawal of cigarette smoking. Then modification of exposure to irritating substance within the home and workplace. These are the major non-pharmacological approaches towards chronic bronchitis. The treatment options of this chronic bronchitis are ampicillin 0.25 to 0.5 QID. Then amoxicillin should be given TID 0.5. Then cefuroxime 0.5 BD. Then cefuroxime, ciprofloxacin, gatifloxacin, levofloxacin, doxycycline, minocycline, tetracycline are some of the treatment options. Then supplemental drugs, antibiotics such as azithromycin 0.25 to 0.5 OD can be given. Then erythromycin, clarithromycin, cefixime, cephalexin, cefaclor can be also included in the therapy. Important lower respiratory tract infection is pneumonia. An infection, as we all know, of lung which can be caused nearly any class of organism known to cause human infection. These include bacteria, amoeba, virus, fungi, and parasites. Inflammation of lung parenchyma characterized by consolidation is there. Then classification based on the place of origin, that is community acquired or hospital acquired. Epidemiology in US, pneumonia is the sixth most common disease leading to death. 2 million Americans develop pneumonia each year, and approximately 40,000 to 70,000 persons die from it. And pneumonia is also the most common fatal infection occurred by already hospitalized patients. According to 2008, pneumonia occurred in approximately 156 million children. In 2010, it resulted in 1.3 million deaths, and 80% of all deaths in those under 5 years, which is 95% occurred in developing world. Pneumonia is due to infections caused by primarily by bacteria, virus, and less commonly by fungi and parasites. Coming to the pathophysiology, pneumonia is caused mostly by bacteria, that is Streptococcus pneumonia, Haemophilus influenza, and by virus, influenza virus and adenovirus. It starts as an upper respiratory tract infection that moves to the lower respiratory tract. Then body filters germs out of the air and be breathed to protect the lungs from infection by the help of cilia and nerves. When it is not filtered clearly, the germs reaches the lungs and immune system goes into action. These cells cause the alveoli to become red and inflamed and filled up with fluid and pus. This causes the symptoms of pneumonia. Major risk factors include certain chronic disease such as asthma, COPD, heart disease, etc. Then weakened or suppressed immune system due to factors such as HIV or AIDS, organ transplant, chemotherapy for cancer, or long-term steroidal use due to their immunosuppressive action. Then smoking, which damages body's natural defenses against bacteria and virus that cause pneumonia. Then being placed on ventilator while hospitalized, that is ventilator acquired pneumonia, VAP. So these all are the major risk factors for pneumonia. So major signs and symptoms include patients with infectious pneumonia have productive cough, fever accompanied by shaking and shivering, shortness of breath, sharp chest pain during deep breaths, and increased respiratory rate. The typical signs include and symptoms in children under 5 years include fever, cough, and faster difficult breathing. Coming to the diagnosis of pneumonia, based on patient's report of symptoms combined with the examination of chest, uh, uh, it will be the physical examination. Then listening to with the stethoscope will reveal abnormal sounds and tapping of patient's back. Maybe instead of dumb, if the alveoli are filled with fluid or debris. Then laboratory diagnosis should be there, that is bacterial pneumonias by sputum analysis and culture. Then we will go for X-ray examination of chest. That will reveal certain abnormal changes associated with pneumonia, that is localized shadows of uh, obscuring areas of the lung may indicate the bacterial pneumonia, while streaky or patchy appearing changes in X-ray picture may include viral or mycoplasma pneumonia. These changes on X-ray are known to lag in time behind the patient's actual symptoms. So these all are the diagnosis of pneumonia. The treatment of options for pneumonia is antibiotics are used to treat bacterial pneumonia, that is azithromycin or ampicillin, erythromycin, and tetracycline. That will improve the recovery for time for symptoms of mycoplasma pneumoniae. Then linezolid is being used to treat penicillin-resistant organisms that cause pneumonia. Then antiviral medications such as amantadine and acyclovir to treat the viral pneumonia. Then fever reducers are included because of high fever. The NSAIDs such as paracetamol and ibuprofen can be used. Then cough medications are included for to calming the cough. Then if pseudomonas species are suspected, beta-lactam with aminoglycoside and fluoroquinolones or macrolides can be included. And if methicillin resistant staphylococcus aureus is isolated, then add linezolid or vancomycin to the therapy. So coming to the prevention of pneumonia, because of many bacterial pneumonias occurs in patients who are first infected with the influenza virus, then yearly vaccination against influenza can decrease the risk of pneumonia, particularly for the elderly and people with chronic disease such as asthma, cystic fibrosis, of the other lung or heart disease, sickle cell disease, diabetes, kidney disease, and some other forms of cancer. A specific vaccine against streptococcal pneumonia is very protective against this and should be administered to patients with chronic illness. So that's all for respiratory tract infection. Thank you.